Hello and welcome back for part 2 of our introduction to point-of-care ultrasound, where today we're going to go over the thrilling sequel and talk a little bit about some of the common terms and artifacts that you might see, just so you can start recognizing what images look like. We're going to talk about how to acquire images and how to think through that, and how what your hand does affects what you're going to see on the screen. We'll just barely touch a little bit into documentation, safety, disinfection, and then we'll do a really quick overview of what just some basic tissues look like. And then we'll finish it all up, a quick introduction on how to incorporate the ultrasound information that you get clinically into caring for the patients in front of you at the bedside. Let's get started. So next, there are a few other modes that we use in some other special areas, but for our intro, we're not going to talk about those. A few, just the basic terms and common artifacts that I want you to be familiar with. Probably the most important term is echogenicity. So you'll hear us talk about what structures look like. Are they echo-dense, sono-dense, or hyperechoic? That usually means they're more white. And if we say hypo-dense or hypoechoic, then that usually means they look more black. So here are the examples here. So this is a hyperechoic structure, and we usually talk about them in relation to whatever the other tissues around them are. So this structure is hyperechoic compared to the other tissues around it. This one is hypoechoic, it's a little darker. This one you can barely see because it's iso, or it has about the same echogenicity as the other surrounding tissues. And this one, maybe sometimes you'll say, there's no other, it's all completely black. That's anechoic, meaning there's no echo or no reflection from anything inside there. And sometimes you'll get these little edge artifacts or shadows that come down off of these curved structures that look like that. So think hyper, more white, hypo, more black, hyperechoic, hypoechoic. I always like to show some real world examples of these kind of things. So here's a couple where we're looking at kidneys and different findings in the kidneys. Here we've got hydronephrosis causing the hypoechoic urine to back up into the collecting system. So that's what we see here. It's hypoechoic compared to the rest of the tissues. Or in this case, we've got a large stone in the collecting system, and it is hyperechoic compared to the rest of the surrounding tissues. It's very bright white, and often dense things will cast an acoustic shadow, which is something we're going to see coming up soon. You'll hear us talk about acoustic windows. Acoustic windows are structures that help us see other structures, usually that are deeper than the windows themselves. So things that transmit sound very well are usually fluid density. So a bladder, sound pretty much travels right through a bladder, and that can act as an acoustic window to help us more easily recognize and identify the uterus behind the bladder. So the bladder itself acts as a window. Or sometimes if we're doing this subcostal view of the heart, we will actually shoot the beam through the liver, and normal livers are about water density, so the sound travels very well through the liver, and that helps us better visualize the heart from this window. So the liver and the bladder in these cases are acting as what we call acoustic windows. And then if we get into artifacts, the most important artifact to know about by far is probably shadow artifact. And this is just something that happens when the sound waves come down, they strike some dense structure, and then they reflect back. And if the sound isn't going through, then it's going to cast a shadow, just like the sun can't get through me. So when the sun hits my back in front of me, I have a shadow. These can actually sometimes be helpful because they help us identify structures like these gallstones and this gallbladder. Sometimes they can get in the way. So here we're trying to look at a kidney, but we get these shadows going through our image because of the ribs that are up here casting a shadow on our screen. So just because it's an artifact doesn't necessarily mean it's bad. We just need to recognize it and know how to incorporate that into the image that we're seeing. This artifact, not as common, but it can be confused with the other shadows, so we need to recognize it. When we have some curved structures like vessels, or sometimes it's a gallbladder, we can get an edge artifact or an edge shadow. They always stay on the edge of our structures. No matter how we adjust our image, we're going to see these shadows kind of moving around because they're following the edges of our structures, and they're not to be confused with shadows. So you don't want to think that, oh, this means there's calcium in this carotid artery. It's just a normal edge shadow. Or if we see them coming off of the edges of the gallbladder, we don't want that to confuse us and think that's because of a stone in the gallbladder. We just need to recognize it for what it is. It's an artifact. And then the other one, there are lots of variations on this one, but it's a common artifact, and it's called reverberation artifact. Usually it's because of the ultrasound coming in contact with something that's very dense, that maybe even vibrates a little bit when the sound hits it, and then the sound bounces back and forth from that structure to the transducer and creates this what we call reverberation artifact. And this one is sometimes known as ring down, because we have a dense needle here in the tissue, and that needle is causing multiple rapid reflections that give us this reverberation artifact. And in this case, we have the wire in the blood vessel. The thin piece here is the wire, and then coming down off of that is all this reverberation artifact. Sometimes this gets in the way, sometimes this helps us identify things, but we need to recognize it for what it is. This last one mainly comes up in limb imaging or musculoskeletal imaging. It's called anisotropy, and this is something where when the ultrasound beam strikes some structures, usually tendons or nerves, we like the beam to come in a very perpendicular fashion to those structures so they kind of keep their normal appearance. If we're imaging them from a certain angle and it's not perpendicular, then that can make them falsely appear dark. And dark, especially in a tendon, can be associated with pathology like tendinitis or inflammation. So we just have to be careful that if we see this kind of finding, that it's not due to anisotropy, that it is actual pathology. Here we see bicipital tendon. This is pretty normal looking bicipital tendon. Here it looks artificially dark because we're imaging it at a poor angle, and it's due to anisotropy. So we just have to watch out for that, and we can usually mitigate it by changing the angle from which we're imaging. All right, a few little tips about image acquisition. That's pretty much it on physics and artifacts. So when we're acquiring images, there's a few tips. We want to try to be as perpendicular to the structures of interest as we can. That way more of the sound energy strikes the object and then comes straight back to our transducer so we can get good images. If we're at an angle, then some of those sound waves are going to bounce off and never come back to our transducer, and that's going to degrade our image. So try to be perpendicular to our structures as best we can. Always, one of the first things I always do if I'm having trouble and an image doesn't look good is I make sure, did I pick the right probe? Am I in the right exam or setting? There are a few things to optimize patient positioning. You want the patients to be comfortable. There are some things that are better with them sitting up or flat or on their left side. So just whatever exam you're doing, get the position as optimal as you possibly can. Make sure you use plenty of gel. Don't be afraid of the gel. It needs to be coating the patient and form a nice layer between the transducer and the patient's skin. We're going to talk a little bit about transducer movements. And if you're first learning ultrasound, you want to try to mindfully think about what your hand is doing with each movement and how is that affecting your image. If you kind of think through what your hand is doing with each movement and then how did it help your image or not help your image, that's going to help you gain your skills a little bit more quickly than just kind of random movements and not really paying attention to and being mindful about what your hand is doing to affect your image. We're going to use acoustic windows wherever we can. You'll hear us talk about those as we get into certain applications. The respiratory cycle can often be a helpful thing to help you see things. There are certain structures that we see better when the patient takes in a big inhale. Some structures can be seen better when the patient exhales, and we'll just have to work with that. There are some structures where you have the patient breathe and you get to, okay, stop right there. That's where I see your heart the best. And you just have to work with that. But the most important thing is this is a procedural skill, and it's like any other procedure. A lot of times it's compared to playing a video game. You get good at it by doing it repetitively, especially if you can be mindful about how you're doing it and how your hand is moving to affect your image. That's what's going to make you better at this. The less you listen to me really is the better, because the more you practice is what's going to make you better at doing ultrasound. It's all about practice. All right, let's talk a little bit about some specifics of acquiring the image. The first thing is you need to hold it in your hand just like it's a pencil and you're making art on the patient's body. That's how I like to think of it. And your hand, the base of your hand needs to be stabilized on your patient's skin. If you're not touching your patient when you're doing ultrasound, you're doing it wrong and you're going to struggle and it's going to be a lot harder for you. And we're going to talk about kind of 4 basic movements that you do with the probe. So even though it sounds kind of silly, I guarantee you if you think what movement am I doing and how is that affecting my image as you're practicing, that's going to make you gain ultrasound skills a little faster. And the movements are sweep, or sometimes called fan, then there's rock, rotate, and slide. And we're going to demonstrate those just a little bit. So here's a cartoon of it. Here's a demonstration of sweeping or fanning. This is the indicator towards the patient's head, and we're just fanning. And when we fan, we're moving the beam either towards the head or towards the feet or towards the right or towards the left, and we're moving perpendicular to the axis of the ultrasound beam itself. So one more time, sweeping right, sweeping left, sweeping right, sweeping left. We're talking about in relation to the patient, sweeping to their feet, sweeping to their head, sweeping to their feet, sweeping to their head. Next up is the rocking movement. So we see again the indicator is towards the patient's head, and we rock in the same plane as the ultrasound beam. So we can rock the beam towards the head, towards the feet, towards the right, towards the left. Now we're rocking towards the head, towards the feet, towards the head, towards the feet. Now we rotate, rocking patient right, patient left. Patient right, that's rock. Now we're just going to slide, and we may slide to the head, to the feet, to the left, to the right, sliding wherever we think we need to. That's the most straightforward. And then lastly, and this is usually the last thing we want to do, after we find a structure and we're kind of happy with how it looks, we want to see a different view, we rotate. We don't usually want to rotate when we're searching. We do the rotation after we've already found the structure of interest. When we're searching, we want to fan, rock, sometimes slide. We want to rotate after we've found our structure of interest and need to change the view, or maybe we need to optimize the view with a little bit of rotation. So when we look at our views, and I kind of alluded to this already, our standard views are generally with the indicator towards the patient's head or towards the patient's right. And so when we have the indicator towards the patient's head, maybe on the main part of their body, we have essentially a sagittal view. And so this is the head up here, feet are here, this is always superficial and this is deep, and we can kind of see how that slice is taken out of their body. When we have the indicator to the patient's right, then we're taking a section basically out of like an axial CT slice, where it's the patient's right over here, patient's left, and you can see how this slice is taken out of their body. And those are our standard views. There are times, however, and this is one of the powerful pieces of ultrasound, where we can take different structures and image them from pretty much any plane that we want. And we need to do this and sometimes for anatomical structures that don't lie straight up and down or horizontally in your body. And so we'll often refer to structures in their long or short axis, and we'll obtain views along these long or short axes. In this example here, we've got the transducer oriented along this plane to get a long axis view of the heart that looks like this, where we see full length of the left ventricle, or maybe along this where we have the short axis view of the heart where we see a cross section of the left ventricle. So long and short axis may be something else we do rather than just a standard sagittal or transverse image of the patient's body. And just in case you like emojis, this is the example I use for some of my other learners, is long axis and short axis. We can all agree that this eggplant has a long axis and a short axis, and if we need to, we could make slices of this to grill it or bake it or whatever, and we would get short axis slices or long axis slices that look like this depending on how we slice it. Ultrasound is really just doing the same thing to some of these structures. Kind of like we alluded to before, long axis of the heart in the left ventricle, or short axis cross section left ventricle, depending on how we orient our transducer along the long axis plane of the heart or the short axis plane. All right, that's some basic imaging things. Let's talk a tiny bit about some other things, documentation. So things that need to be on anything that you're going to store in the patient chart are the patient's info, demographics, and hopefully we'll have systems set up for you where you can just kind of pull them off of a work list and you're not typing all this stuff in manually. To document for quality purposes and for if you're doing billing, you need to have permanent storage of the images and clips. There needs to be a medical indication for the study itself and interpretation that's signed by the physician. Those are just kind of important things and how we're going to plan our processes moving forward. Little bit about safety. The nice thing about ultrasound is it's super safe, so there's not a lot to worry about here. There are theoretical things that you can think about, but none of these are really an issue with diagnostic ultrasound and the energy levels that we're using to image patients. But sound, as you know, can destroy tissue. There are thermal effects, so it can heat the tissue, and mechanical effects where you can form bubbles that burst in the tissues. Again, doesn't really happen in the diagnostic range, but important things to know about and just concepts. So if you really want to get into physics, what happens with ultrasound is it's a longitudinal wave that goes through the tissue, and there are areas of compression and areas of decreased pressure or rarefaction where the molecules are compressed or spread out as the sound moves through the tissue. But as I said, no documented harms to humans from any diagnostic ultrasound at diagnostic levels. It is still important to recognize and use what we call the ALARA principle, as low as reasonably achievable, and be careful for any potential effects even if they haven't been documented yet in any human tissue. The areas that are going to come into play a little bit in anything that we might do is in the retina or in the first trimester fetus. So these tissues are at least theoretically sensitive, and we want to be careful with them, so we try to not overblast them with ultrasound energy unnecessarily. What we need to know, I don't want to get into too many details about this, but there are FDA approved ophthalmic or ocular settings that should be used when we're doing ocular ultrasound, so make sure you use those. And if your machine doesn't have one, you shouldn't use it for the eyeball, and that's just how it goes. These settings that are FDA approved for the eyeball use lower amplitudes and lower energies to help just protect the sensitive retina. And then first trimester fetus, again, no documented harms have been shown, but we still just want to be judicious about how we're using the energy and putting ultrasound imaging into the tissue. We want to use the lowest energy modes, so B mode and M mode are very low energy ultrasound modes, so that's what we want to use when we're doing first trimester fetus evaluation. We do need to do educational scanning, and that's perfectly okay, but we don't want to overdo it. We don't want to go crazy about it and just have people going willy-nilly for hours on first trimester fetus. And there are good recommendations not to be doing recreational scanning. People having their home ultrasound machine and looking at their baby every hour, every day is certainly not recommended. That's really it for safety. A little bit about disinfection. Most of this is pretty straightforward. Essentially, for disinfection purposes, different medical instruments are broken into critical and semi-critical or non-critical devices. Pretty much anything we do with ultrasound is all non-critical because it's all on intact skin, and just percutaneous punctures where we're using sterile sleeves over the ultrasound probe to help prevent any contamination. So for anything that's non-critical, we can use kind of the standard Sandy wipes that live all over the hospitals, and that's how we can disinfect our probes. If we are doing endocavitary things like transvaginal, transrectal, there are a few things where we do intraoral. Those are considered semi-critical, and those need high-level disinfection, which in a lot of our areas where we've gone to the Trophon, which is a nice disinfection tool. More on that later if you're interested. But almost everything you're going to do, including percutaneous IV sticks with a sheath over the probe, that's all non-critical. Sandy cloth sanitation is fine unless you're very worried that there was blood contamination or something on your probe itself. And that's considered low level. Sometimes people will split hairs about intermediate, but that's just low level disinfection. All right, just a little intro into basic tissue appearances. We'll get into this in more depth when we get into certain applications and organ systems themselves, but a little bit about some of the tissues. So just generally, bone, you can really only see the edges of bone. So bone is white. So here's the edge of the cortex. So this, I think, is a distal radius. And then you mostly get shadowing and some reverberation artifact behind the bone. So you just see the edge. So it's white with usually kind of dense, dark shadow. So here it is. Here's an example of a bone that's fractured. You know, the cortex doesn't line up anymore. So that's what bone looks like. There you go. You can use it to diagnose fractures. Air also looks white. So it's not always density that determines whether it's white or not. We don't need to get into the physics about that now, but so air is white, but it causes streaking and not really shadowing, or sometimes this is called dirty shadows. So here, this is kind of bowel gas or some other air that's streaking out everything. Or in this example here, we're trying to find the gallbladder, but we've got some bowel gas here. You can see those streaks coming off. So that's the streaking or dirty shadows of air and what that causes. So that's what air looks like. Fluid is generally black, and everything behind it should look brighter. So these are some examples of, here are some abscesses here. So this is fluid in an abscess, and you can see how everything is brighter behind it. That's called posterior acoustic enhancement, or you can just say it's bright behind the fluid. If you see something that looks like fluid, but it doesn't get bright behind it, then there's a chance maybe it's not fluid. So look for not only the blackness of the fluid, but the brightening behind it. So another abscess here, acoustic enhancement or brightening behind. And here, maybe it's not quite as well demarcated, but we see the fluid in the collecting system, and it's a little brighter behind this. So fluid is black, deep brightening. Soft tissues themselves, so if we look at the upper extremity, maybe we're worried about cellulitis or an abscess. Soft tissues have some pretty well demarcated layers if you're paying attention. So we see kind of the dermal layer up here, which normally is nice and thin. There's not much to it. There's a little bit of subcutaneous fat. No matter how thin you are, most of us have a little layer of subcutaneous fat, which is just pretty sparse. There's little bits of connective tissue out through here. We have some nice fascial planes, and then we see muscle, which is a little darker with a little more connective tissue flex in it, and different layers of fascia where the different muscle layers are demarcated. So that's what those soft tissues look like. When there's inflammatory changes or edema, this will change, and we'll look at that later on. And then just, again, this is not a detailed look at the heart, but if you look at the heart, it looks kind of like a heart, right? It's a black and white beating heart. Just want you to get familiar with some tissues before we get into a lot of detail later on. So this is the heart, left ventricle here. This is the left ventricle, this is the right ventricle, but we'll get more to that later on. Here are some other abdominal tissues. So the liver, a lot of these glandular organs have the same kind of appearance, like the thyroid, the liver, they all look about the same, where they're kind of this speckled gray. And so that's what the liver looks like. The spleen looks almost the same. We can see the kidney. I think the kidney just looks like a black and white representation of a kidney. So a lot of those organs are going to be pretty recognizable, hopefully, for you. The gallbladder is filled with fluid, bile. So fluid, you can see, looks black. And here's the blood in the portal vein. It looks black. This is an eyeball. So this is just the anterior surface and the anterior chamber. This is all the vitreous chamber back here and the optic nerve. We'll get into more detail on this later, but just different tissues, starting to get familiar with what they look like. Here's some vasculature. So arteries, they don't compress very much, and veins should compress pretty easily. So you watch this vein compress as we work our way through this video. So the vein is collapsing, the artery resists compression and pulses and has a thicker wall. Just other examples. So that artery is hard to compress. If we push hard enough, it'll compress, but it's also pulsing. And then over here we see a little vein that's very easily compressible, as a thin wall, and it doesn't really pulse. So that's some of the things we see in the vasculature. And tendons and ligaments, they look about the same. You just recognize them from where they are and what they're attached to. So this is the Achilles tendon. It's this tight linear fibrillar appearance. So this is I think this is the subscapularis tendon here, and you have to remember these have the properties of anisotropy as well. So that's just some basic tissues. Again, just getting your eyes starting to get familiar with what those look like, and then a little bit about just the clinical approach to ultrasound and point of care ultrasound, and how it's different from comprehensive or radiology ultrasound or other imaging specialists. Most of the time you want to go into this with an approach of a yes or no question, or trying to evaluate a specific syndrome of why is this patient dyspneic, or why is this patient having this right lower quadrant pain. A lot of times that's yes or no questions. Sometimes we're going to use ultrasound to either raise or lower our clinical suspicion or our threshold for whatever else we might do. So in appendicitis, maybe we say, look, I didn't really see the appendix, but I saw all the anatomy and the landmarks well. There were no secondary findings. That, combined with the rest of the clinical picture, lowers my suspicion enough that I don't need a CT scan at this time. So we can just use ultrasound to raise our clinical suspicion or lower it, and change our threshold on other imaging or other testing or other steps in the workup. Many times we can shorten or even just confirm outright what we're worried about in our differential diagnosis. And we'll talk about that a lot when we look at things like shock and chest pain and things like that. And then kind of separate from all the diagnostic things is using ultrasound as a procedural guide or an aid to our procedures and help us visualize anatomy, and a lot of times help us guide our needle towards a target or a structure of interest. And that's our intro. We'll get into some more details with some of the applications later on. So we can use ultrasound for pretty much every organ system. It's not just limited to babies and gallbladders. And there are specific clinical scenarios or syndromes where we can use it in a systematic way to help us manage our patients and not make mistakes. And we can use it for procedural guidance, and we'll get into that a lot more with some of the applications later on. So it's a great clinical tool. I have to tell you, I am a person who I trained before ultrasound was really a thing. I didn't know how to use it. As I started to use it and incorporate it in my practice, I know that I've become a vastly better physician with it as a tool in my toolkit. So I hope it can be that way for you as well. Remember the basic things: pick the right probe, and then the exam or setting. And then the only things you really need to mess with after that are the depth and the gain. And that'll get you as far as you need to get for most things. And then remember, high frequency is superficial, low frequency lets you see a little deeper. When we say things are hyperechoic, they're bright white. If they're hypoechoic, they look closer to black. Hold this thing like a pencil with your hands stabilized on your patient. You have to be touching the patient to do ultrasound. And then really think about, when you're first learning this, what movements are you doing? How are they affecting your image? And break them down into the kind of sweep, rock, slide, and rotate. Rotate is always last after you've already identified the structure of interest. And that's everything I have for you. Thanks for spending a few minutes. I hope it was helpful. And we'll see you soon as we dive into some of the specific applications. Thanks a lot.